I feel like I'm being pretty clear. Am I being clear? Like, am I saying it in the right way with that it's making sense? Because sometimes I can say things that don't make sense.
I think you're clear. I think for me, it was like, I didn't get a chance to look at this stuff when you were talking about it, in class. So now that I had a chance to sit down yesterday, I just needed some clarification.
Okay. I'm pretty sure, Charlie, Brandon Sharp, they're in two separate courses. So Brandon Sharp is in the Simmons complex care course, and then Skylar Hansen, or are they in the same one?
No, they're in different.
They're in two different
I'm
ones.
in both, and I don't have it anywhere.
Okay, well, that doesn't make any sense, my friend.
I know. That's why I'm telling you.
It doesn't make any sense.
You don't have to figure it out right this second. I'm just giving you a heads up, I guess.
You're not on my roster, Charlie.
Oh, wonderful. I love that for me.
Mm-hmm. Which means you're not in the course.
When a second nurse must compare.
So
I have everything else.
did you copy and paste the course codes that I sent you?
Yeah, but that's what I was saying. The one wouldn't work.
That's because you need a book code for the other one.
I have the book code. The second code wouldn't work.
Okay, so I'm gonna need you to send that back to Terry.
Okay.
She needs to look upcoming assignment.
And did you look under upcoming assignments?
Yeah. Yep. I've
Oh,
looked
well,
under
she's not even in the
everything.
course. She's not on my roster. She's not in the course. Okay. You have to have the VSIM book code first, correct? Then the course. Yes, correct. I have
Yes,
the cases
I
in place.
get
Doesn't
that.
matter
I
which one I
have
can
both
read them in.
books.
Yeah, Charlie, like I said, I don't see you on the roster, which means you're not enrolled in the course. And that means that either the code is bad or something with the code.
Okay,
Thankfully, it's
I
not
will
due this week,
email.
next week.
Right. I'll email Terry, but like I have the VSIM book, but the one course code in the email wouldn't work for it. So I'll email her.
Well, that's because, well, it might, I don't know, maybe the code is the wrong VSIM book because you're not enrolled in my VSIM course.
It says critical care Simmons.
I don't know. Can you share your screen?
I don't have my computer anymore. I have no idea how to use this little tablet and do that, or I totally would. My
So you're
laptop
in
broke.
Central. At the bottom, yeah, at the bottom of the screen. Kaylee, if that's your book code, that's only your book code.
No, that's not the book code. Everybody, this is the one that everybody has on Brightspace. This is not the one Terry sent me.
Yeah, the one, I think this is the one that won't work for me.
Oh,
the one with the J in it. I'll try it again right now.
We'll have to, and make sure you copy and paste it. Like, don't type it in. You have to actually copy and paste it.
Okay.
I don't know why. Don't ask me why. I don't know why. I think it's so stupid.
Miss Simmons, whenever you get a second.
At the end. Yeah.
I'm on my computer.
Okay.
It also
Thank-
won't work if you do any space.
Miss Simmons,
It won't work if you copy. Yes, what?
So for the assignments VSIM, we have to do the pre-quiz, the VSIM post-quiz documentation assignments, and the guided reflections questions for the 2 assignments on the course schedule, not the clinicals. Because there's 4 different parts to the.
There are 4 different parts. There's the 4, let me see what's on the syllabus, because I have always only required the test. Yeah, here, let me. Oops, that's not what I wanted to do.
I think it's the pretest.
Essentially, there's like
I'm gonna share it.
And then there's also the packet. We don't have to do the clinical packet,
No.
but there's the 4 other things.
This is on the syllabus. You have to do the pre-quiz, the scenario, the S-bar, and the post-test. That's it. Just those 4 things.
And that was the one you said that you're not going to fail us if we don't get 100%. Is that correct? That was the scenario you told us about.
If you put in the effort and spend
Right.
enough time like in the virtual simulation and you're not getting over an 80% or whatever, like, no, I'm not going to fail a student over a VSIM.
Okay.
But if you stay in there for 3 seconds, click a bunch of stuff and fail it and then expect to get 400 points, you're not going to.
Right. And then we could do it again. Can we do it again if we
Yes.
wanted to? Okay.
Absolutely. I actually recommend you do it the first time, because especially if you're not used to doing VSIMs at all, you do one and you're like, oh my God, like, what was that? What just happened? Because I have students that have never done a VSIM in their life. And then I have students that did a VSIM for a whole entire month straight and they can do it in their sleep. So if you are one of those students versus another student that's never seen one before in their lives, like, I don't think that's fair. I don't think that's fair to have one attempt on a VSIM where someone is a pro and the next person's never seen it before in their lives. They don't even know how to use the programming, and then fail them. Like, that's not okay with me.
No, because my first one, I definitely killed the kid.
Right, that's what I'm
Like,
saying. Like,
immediately.
and
Yeah.
like, that's the point of a virtual simulation, is that you're allowed to kill them. Okay. We need to get started.
That was the gone. Those things are hard.
Miss Jess, I know you're ready to get started, but I just have one last quick question.
Yeah.
Because I know that you sent an email about those assignments for the video case studies on ATI about doing the parental nutrition. Because on ATI, I did the one that said nutrition ADL, and then when I went to the syllabus,
not-
it said it was listed in the syllabus, the nutrition ADL as well, and this and they're listed
it's
for
not.
Bright Space as an assignment.
What?
It is listed on the syllabus. But
Yeah,
when
it's
you went
listed
the
on Bright
syllabus,
Space
you
and
said
in the
that you did
syllabus.
typo.
Hold on. Oh, it is.
Under
It
week
is.
one, if you
I
just
want you to
look
do
at
total parenteral nutrition, and I want you to do the other enteral nutrition, not the ADLs.
so then put the other one where the ADL one is supposed to go.
Yeah, that's fine.
Okay.
I even sent out an email.
Well, under week 1, too, it shows us what assignments are due. So if the syllabus is wrong or whatever, you can just look at that.
Is it right in the week?
It's
No,
like,
it don't
It's right
say
on
that
Bright
in
Space or
on
Pulse.
Bright
Yeah, it
Space
is.
either. That's why I went on there. It
On
doesn't.
Pulse,
It
it
just
shows
says
you, it
nutrition
shows
on
us what
Bright
you want
Space.
us to do for the week, and it shows us what to upload. So yeah, it is right on Pulse.
Okay. We need acid-base balance, blood administration, blood transfusion, nutrition, total parenteral, nutrition enteral, and then we're going to go over the ABG worksheet today and do that together. Okay?
I have a question about the worksheet. Well, it's not really a question. It's to print off the paperwork because I was planning on doing it today when I went on campus after the math test. Since I didn't do that, can I just write it on like a regular notebook paper? Will you accept that if I like transfer it over or?
Yeah, that's fine. We're not going to be doing that whole worksheet together. We're going to do most of it, and then there's going to be more for you to do on your own. So whether
okay.
you want to, yeah, so it's And really, if you print it later on, it would be even better for you to have more practice to just redo those on your own to make sure that you understand the content.
Right. Okay.
Because ABGs are huge. They take up, I mean, I'm not kidding. Blood gases are the biggest component of what we're learning this month. Like, and follows through into the next month. So you guys understanding blood gases is imperative.
They draw those a
So-
lot on the ICU, like a lot.
That is
ABG.
correct. Mm-hmm. I do not have Skylar Hansen as in my lipid cut. Okay. We're gonna have to deal with that later because it's already 10 o'clock and we need to get started. Okay? Are we ready? Am I recording it? Yeah. Oh, boy. I really hope they fill my antibiotics by lunch because I really need some support here. All right. So we left off at potassium, right? So am I sharing my screen? Why isn't it up there?
I can't see anything.
Okay. There we go. There it is. Okay, so we left off with potassium. We have hypo or hyperkalemia. Normal levels are 3.5 to 5. Our functions include balances with fluid volume because there's a sodium and potassium pump. Nerve transmission, heart contractility, which is basically the most important one because we can die from that. And overall muscle function. So hypokalemia is anything less than 3.5. You have 6 L's, lethargy and confusion, leg cramps, limp muscles, low, shallow respirations, lethal cardiac dysrhythmias, like a T wave inversion, and lots of urine, which is polyuria. Okay. This can be caused by being NPO for a long period of time, fasting, malnutrition, anorexia, movement from potassium from the extracellular fluid to the intracellular fluid. Remember, I told you one thing I really, really wanted you to know and remember is that potassium and insulin follow each other. So when you give a patient insulin and the insulin goes into the cell, potassium will follow. And that can cause the patient to be hypokalemic. Okay, this is a very important concept that I need you to understand. When you give a patient insulin and the insulin goes into the cell, potassium will follow, putting your patient at risk for hypokalemia. Which is why excess insulin can cause your patient to become hypokalemic. Also, when we have an acid-base imbalance, potassium can teeter-totter with hydrogen. So if you have a patient that is alkalotic, the body is going to try to compensate by releasing hydrogen ions from inside of the cell, which will cause potassium to go inside. Kind of one for the other, like a 1-to-1. If I give you a hydrogen ion, you have to give me a calcium or a potassium ion, which can, which is your body's way of trying to compensate for alkalosis. When I talk about acid, there is also a very extremely important thing I need you to understand. I want you to write this down at the top of your paper. I don't care where you put it. You will hear me say it 100 times. Acid equals carbon dioxide, also equals hydrogen ions, also equals ketones. Okay, when we talk about acidity and the compensation of acid-base balance, there are 3 ways that our body deals with acid or presents as acid, bless you, which is carbon dioxide, hydrogen ions, ketones, and add one more, lactic acid. So is this why diabetics sometimes have a lot of ketones in the urine? Yes, Marissa, we're going to talk about that next week. Okay. Do I need to repeat that? Believe me, it won't be the first or last time I say it. Okay. All right. So another cause of hypokalemia would be dilution of serum potassium. So if you're hypervolemic, if you have excess water intake, if you have excessive fluids without potassium. So if you're just drinking gallons and gallons of water without any type of electrolyte solution and causing dilution because you're hypervolemic, you're going to have dilutional. Okay. Excess potassium loss, which can happen with potassium wasting diuretics, which your biggest hitter is going to be furosemide, which is a what type of diuretic? A loop diuretic. What's your other common loop diuretic?
Is it Lasix?
Starts with a B. No, furosemide is Lasix.
Bumetidine.
Bumetidine, which is Bumex. Bumetidine. Remember, the NCLEX tests you specifically on generic names, generic medication names, not brand. Okay, so make sure you're able to recognize both names. vomiting and diarrhea, and then NG suctioning. NG suctioning is going to be a huge one. If you take out a person's stomach acid, first of all, it's going to cause them to become alkalotic, which when we just talked about causes them to be hypokalemic. Okay. So if for the treatment, if this is due to inadequate intake or serum dilution, we need a potassium supplement, whether that can be PO or IV. If you have a peripheral IV, you can only give 10 milliequivalents at a time. Okay. In the acute care setting, we call these K riders. They're little cute little bags, 10 MEQs of potassium. And you can only give one bag at a time. If you've ever received potassium, it burns like a bee. Okay. It would, if your patient cannot tolerate it because it burns too bad, because it causes phlebitis, it's a very common adverse effect. You can, depending on if your patient can handle fluid, you can run it with normal saline. If your patient is admitted for a CHF exacerbation, do you want to add more fluid? No, you do not. Okay. We can slow the rate down when it comes to IV potassium. Never, ever, 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 ever in a million years can you ever push IV potassium. You will kill a patient. You will kill them. I promise you that. They use IV potassium via push for execution, like death row execution, because it will cause lethal cardiac dysrhythmias. Okay, so I'm saying this to be very clear. If you catch my drift, you can never, ever, ever push IV potassium. Never, ever, 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 unless your job is to lethally inject people. Okay? If you have a central line, you can give higher quantities of potassium. So 20 MEQs, 30 MEQs, 40 MEQs. Okay? You can give a higher dose of potassium. Only if you have a central line. Okay. Other treatments, you want to hold potassium wasting diuretics. If your patient has a potassium of 2 and you have an order for 40 milligrams of IV Lasix, furosemide, are you giving it? No. I'm not saying that the patient doesn't need it. I'm saying I'm calling my physician first and saying, hey, bro, I need some IV potassium replacement before I can give this Lasix because this dude's going to die because his potassium's 2. Okay. What also needs to be on my patient? A heart monitor. This patient has to have telemetry. Okay. Monitor for EKG changes, monitor magnesium and calcium levels because they're often linked together. Most importantly, with hypo and hyperkalemia, your patient must be on telemetry, okay? And it must be corrected, okay? So now we go to hyperkalemia. The signs and symptoms are murder because it kills you. So M is for muscle cramps and weakness. U is for oliguria and uria. This is coming together because my grandpa is type 2 diabetic, has COPD, CHF. Yep. We're going to talk about all. You're going to have lots of light bulbs. How much urine is considered oliguria for a day? Less than how many mLs?
30.
No.
It's
20.
30 mLs per hour, so less than like 3 or 400.
400. 400. Oliguria is less than 400 mLs of urine per day. Whole day. The normal amount of urine that a human is supposed to make is 30 mLs per hour. A grown-up human. What is anuria? Less than how many mLs per day? And it's not 30. It's close, but it's not 30.
100.
50. It's 50. Anuria is less than 50 mLs of urine per day. Okay. R is respiratory distress. D, decreased cardiac contractility. E is EKG changes. R, reflexes, decreased deep tendon reflexes. That's what DTR stands for, deep tendon reflexes. So on the other slide for hypokalemia, it said inverted T waves. On this slide for hyperkalemia, it says peaked T waves. So causes of hyperkalemia, one is burns or tissue damage, because this causes destruction of the cell. We talked about potassium being an intracellular ion. Okay, so most of the potassium that we carry is inside of the cell. So if the cells become destructed, all of that potassium that lived in the cell is now outside of the cell, causing hyperkalemia. Okay. Addison's disease. If you remember in advanced pharmacology, we talked about Addison's versus Cushing's. Addison's results in hypoaldosteronism, which leads to potassium retention. Aldosterone is the hormone that is responsible for potassium excretion. Okay. Excessive intake of potassium or a rapid intake of sodium-containing solutions. Also, salt substitutes have a large amount of potassium. So if your patient is thinking, oh, I have CHF or I have hypertension and I can't have a lot of salt, so I'm going to use Mrs. Dash on everything, okay? Because it has a higher level of potassium, and a lot of older people already take potassium supplements, boom, they're hyperkalemic and have a potassium of 7. Okay? Medications. I don't know if you remember, but I basically beat this into your brains 3 months ago. And I really hope that one of you remember that ACE inhibitors cause hyperkalemia. If you don't remember it, please write it down. ACE inhibitors cause hyperkalemia. Our only potassium-sparing diuretic is spironolactone. If your patient is taking spironolactone and lisinopril, do you think they may be in a little bit of trouble? Yes. They're at a very high risk for hyperkalemia. Okay? NSAIDs can cause hyperkalemia. And then decreased potassium excretion, which you see in end-stage renal disease, patients that are on dialysis. So if you ever have a chance to talk to a dialysis tech, you know anybody that is in dialysis, you ever have a chance to talk to a nephrologist, it is an extreme, delicate balance. Yeah.
Mrs. Simmons, how does NSAID?
I think it has something to do with the hydrogen. Let me make sure. I was wrong. NSAIDs cause hyperkalemia primarily by reducing the renal blood flow and inhibiting prostaglandin synthesis. This leads to decreased renin and decreased aldosterone. And we did talk about aldosterone. So if you don't have enough aldosterone, then you do not excrete enough potassium. Okay, good question.
Okay, thank you.
You're welcome. My phone is blowing up. Just make sure it's not anything important. Okay. So treatment. Like I said, your patient, whether they are hypo or hyperkalemic, they must be on telemetry. Okay. If it's due to excessive intake, we need to stop the potassium supplementation, restrict potassium in the diet. Okay. We talked about potatoes and bananas, and I think also avocados, and there's a whole list. There's a whole list of potassium rich foods that I told you on Tuesday. I think it would be wise for you to know. If it's due to decreased excretion, then we need to give furosemide, give a loop diuretic that can cause the loss of potassium. If it is extreme and your patient is already end-stage renal disease, then they may require dialysis over anything, like emergency dialysis. Okay? So, if your patient comes into the ED, you're working in the ED, and your patient comes in, they're complaining of chest pain, they don't feel well, maybe they missed dialysis, okay? And they're just like, I just don't feel well, okay? And you get their blood work, their BMP comes back, and their potassium is 6.7. Okay. My immediate treatment is DICK. D-I-C-K. Write it down. D-I-C-K. D is for dextrose. I is for insulin, specifically regular insulin that can be given IV. What is the only insulin that can be given IV? Regular insulin. I stands for regular insulin via IV, intravenous. Okay? C stands for calcium gluconate. Calcium gluconate stabilizes the cardiac membrane, decreases the risk of lethal cardiac dysrhythmias. K, which is the least common out of the rest of the letters, is K-exalate.
Can you spell that?
Spell that.
K-exalate, K-A-Y-E-X-E-L-A-T-E, maybe? K-exalate. Sounds right in my brain. If it's not right, I'm like a letter off. Okay, so emergency treatment for hyperkalemia is DICK. Why dextrose? Okay, this is easy.
Because
giving
pressure is low.
I'm giving IV insulin. If I give IV insulin and I don't give dextrose with it, I'm going to cause my patient to crash. Come on.
So you give both at the same time, the dextrose and the insulin?
Yes, ma'am. You must give them at the same time. Okay. And would I give the insulin first? Hell no. No, I am not giving the insulin first. Okay. If you've ever pushed D50, it is like sludge. It is so hard to push. It takes forever. It comes in this big 50 cc syringe, and you have to put it together, and then you lure lock it on, and you're pushing it, and you're pushing and pushing and pushing. You're like, oh my God, this is taking forever because it's thick. It's like syrup. Okay. So you give dextrose and insulin together. So your patient does not die of a hypoglycemic coma.
This might be a silly question, but do you push your saline flush in between, or do you give your dextrose, your insulin, and then flush?
I don't think it matters. That's not a silly
No?
question at all. I don't think it matters. As long as you flush it first to make sure your IV is patent, that's what matters, you know, the most when we're talking about an IV flush before and after. Because they, go ahead.
Oh, would the dextrose be running like, would that be continuously? And the
No, it's
insulin
given
would be
IV
pushed?
push. It's given
Oh.
IV push. And also, what are you monitoring your patient for?
Arrhythmias.
Glucose.
Hypoglycemia. So you think you're going to take a couple blood sugars during this time period? Also, what if your patient comes in with a blood sugar of 900? Do you think you're going to give D50 with your insulin? Probably not. Probably not. So is there a situation where your provider could say, I want 10 units of IV insulin, of IV regular insulin given. Hold the dextrose. Yes. Only in a patient that is severely hyperglycemic. If you see your patient has a blood sugar of 250 and he's telling you to hold the D50, you're going to look at him like he's cuckoo nuts bananas. You're going to give him the syringe and say, you push it then, because I'm not killing somebody today. Okay. So that's where our clinical judgment comes in, and evaluating our patient. Okay. This is huge. Hyperkalemia, the treatment of hyperkalemia is very important and a subject that I need you to know and understand. Okay. What is the point of the insulin?
Potassium.
I just told you. Yes, it forces the potassium into the cell. Is this a permanent treatment? No. This is a temporary treatment that is going to save your patient's life. Okay. The root cause of the hyperkalemia needs to be dealt with, because this is a temporary fix so that your patient doesn't die, and it buys you time to treat the underlying cause. Okay. What is the calcium gluconate for?
To stabilize the cardiac arrhythmias.
To stabilize the cardiac membrane. So it decreases the risk of a fatal cardiac arrhythmia. Is it going to take away the risk? No, it just decreases the risk. It's kind of like a little safety blanket. A little, here you go, you're on fire, but here's a sip of water. All right, any questions on hyperkalemia? It's probably the most important thing we've talked about so far. All right. Magnesium. I think that these levels might be a little different on that ATI paper. So like I said, make sure you're looking at your ATI paper that I gave you on Brightspace. The function is that it relaxes muscles, specifically the smooth muscles. Also, and that includes your smooth muscle in your respiratory tract. So this is why patients that are asthmatic, they sometimes get treatment of magnesium, because the magnesium will relax the smooth muscle in your bronchi. causing a decrease in bronchoconstriction or bronchospasm. Okay. It does do a little something for cardiac function and regulation of blood glucose. Hypomagnesemia. There's a little very important thing right at the bottom of your paper here. I want you to put a big fat star next to that says, also seen in hypokalemia, magnesium and calcium rise and fall together. So remember, our sodium and potassium are on a teeter-totter, right? Our magnesium and our calcium, they rise together, they fall together. Okay, they're besties till the end. Your sodium and potassium are like frenemies. Okay.
Miss Simmons,
So,
could you repeat what you just said?
She said
magnesium and calcium rise and fall together. So they go up together, they go down together. Okay. So with hypomagnesemia, you want to think everything is high. You're tachycardic, you're hypertensive, you have hyperreflexia. Those deep tendon reflexes are hyperreflexive. Okay. You have a fast respiratory rate, and you are in a hyperactive state, irritable, you're at risk for seizure activity, twitchy, confused. The signs of hypomagnesemia are the same signs as hypocalcemia because they rise and fall together. So you're going to see a positive Trousseau's and a positive Shostak's with hypomagnesemia because you also have hypocalcemia. Am I making sense here? All right. So Trousseau's is when you have a blood pressure cuff on your arm and it causes a spasm of the hand. Okay. And Shostak's is a spasm of the facial muscles with a light tap over the facial nerve. Okay. Causes would be insufficient intake. So malnutrition, anorexia, vomiting, diarrhea, NG suctioning. Also, when we talk about anorexia, there's a difference between anorexia and anorexia nervosa, right? Anorexia nervosa is an eating disorder. Anorexia is not having an appetite. So say your patient is on chemo and they're not eating because they have no appetite and it makes them feel like shit and they don't want to eat. That's also anorexia. It's a different form of anorexia. The term anorexia itself is just the act of not eating. The cause of the not eating is what differentiates. Okay? So when I say anorexia, I'm not talking about anorexia nervosa per se. It's just the act of not eating. Okay?
Okay, so if you have, so basically a bigger person can have anorexia too, then.
100%, yes. 100%. An obese person can have any eating disorder and can be malnourished. 100%. Another cause would be increased excretion, like diuretics and excessive alcohol use. And then intracellular movement of magnesium. This happens with sepsis. And it also can happen with hyperglycemia and insulin administration. So your potassium and insulin go hand in hand. It is a direct link to hypo or dropping your potassium. Okay. It happens with magnesium, but not so significantly and not like I'm going to kill you. Does that make sense? Like it happens, but it's on like a lesser scale. Okay. For the treatment of hypomagnesemia, we have magnesium supplementation, which can be PO or IV. You want to give this very slowly. It can be given by IV push. I remember the first time that I saw magnesium IV on my MAR, and it literally said in the directions to give over, I want to say it was like 5 minutes, because you could literally kill someone. Like, it literally said like it could cause some type of cardiac like dysrhythmia. And I was so, I'm like, are you so for real? Like, you really want me to push this right now? But there's a reason why it has you push it slowly. Okay. You absolutely want your patient to be on seizure precautions. And magnesium-rich foods, which include chocolate, bananas, cauliflower, avocado, pumpkin, carrots. Okay. Questions on hypomagnesemia? Okay. Now let's talk about hyper. So it's the opposite. Everything is low. You have low energy, drowsiness, even coma if it's very, very high. A low heart rate, low blood pressure, low respiratory rate, low strength, low bowel activity. Okay. This can be caused by an excessive intake of magnesium containing antacids like Tums, or magnesium is also found in laxatives like magnesium citrate, and then an excessive amount of magnesium supplementation. An increased secretion into the extracellular fluid. This can happen, we see this a lot in DKA, diabetic ketoacidosis, which causes a fluid shift and causes more magnesium in the blood. We're going to talk about DKA a lot next week. And then decreased excretion, like renal insufficiency. Your kidneys just aren't getting rid of the excess. Okay. So treatment includes diuretics, decrease magnesium intake. You want to restrict diet of magnesium rich foods, hold all magnesium containing laxatives and antacids. Calcium gluconate, it binds to the excess magnesium and potassium in the blood. So remember, calcium hypermagnesemia would also cause hypercalcemia, right? Because they rise and fall together. Yes? So calcium gluconate, it's not treating the calcium because the calcium's already high. The job of calcium gluconate is to bind with the excess magnesium. Okay? Because looking at that, you could be confused. Why would I give calcium gluconate if the patient's already hypercalcemic? That makes sense. I understand why you're thinking that. I hope you're thinking that. But it's because it's binding to the excess magnesium. If it binds to the excess magnesium and the magnesium goes down, you automatically have a decrease in calcium because they rise and fall together. Okay? Your last resort is going to be dialysis. Everything that's hyper, you can resort to dialysis if it leads to that. Okay? So our next one, what time is it? I have to pee. Let's take 5 minutes. I'm gonna run to the bathroom. And I'll be right back. Okay. I really need CBS to get me the goods, because I am not my best self. I am just not my best self. All right, so calcium. This is going to be hypo or hypercalcemia. Functions include muscle contraction, bone formation, blood clotting, hormone regulation, specifically in regards to the thyroid and parathyroid. Hypocalcemia, your signs and symptoms. You have hats go numb. C is for convulsions. A, arrhythmias. T is for tetany, which has a arrow that goes down to the muscle spasms. S is stridor and spasms. Do you know what stridor is? Stridor is a narrowing
lung
of
sound.
it's a narrowing of the airway. Once you hear it, you'll never forget it.
Isn't that the death rattle?
No, that is different. The death rattle is actually caused by increased secretions that are stuck in the throat of a person that is passing. It can sound a little stridorous, but stridor in itself is the act of narrowing of the airway.
Like
The
babies
first
can
time
get that with croup too. Babies can get that with croup, correct?
If your baby has become dangerous, you better get to the ER.
Right. My daughter did. That's how I know. She had croup and she had
Yes,
stridor.
it's super scary. And the first time you hear it, like I said, you'll never forget it. The very first time I heard it, I did not work in critical care yet. I was working on a step down unit. It was my very first nursing job. And I was walking down the hallway, and I'm telling you, I was at least 3 doors up from this woman's room, and I could hear her breathing from 3 doors away. And we called an RRT, and she was emergently intubated. It was actually my first intubation that I ever saw, and it was crazy. I mean, she was like fighting. She was fighting. It was bad. It was bad. She was fine. She ended up being fine, but it is like, I don't know. It's like this intense sound of breathing, and think if you're literally breathing through a very small straw. Okay. And then the go numb, that's for numbness in the face, fingers, and limbs. We refer to this as paresthesia. Okay, you see that word, because you're going to see that word. That is called, the numbness and tingling is called paresthesia. And you are going to see a positive Trousseau's or Chauvet's sign. The cause is from impaired absorption, so vitamin D deficiency. Vitamin D is essential for calcium absorption. Increased excretion, that could be caused by kidney disease, diarrhea, or wound drainage. And your treatment is going to be calcium supplementation, whether that's oral or IV. You want to give calcium-rich foods like dairy, sardines, tofu, leafy greens, edamame. I love edamame. Lentils. And this is important. Right here, this is very important. And like it says right here, it applies to both hypo and hypercalcemia. Patient is at risk for pathological fractures. That means the fracture is caused by the disease, the pathology of hypo and hyperkalemia. So your patient is at an increased risk for falls and safety precautions. So you need a bed alarm. You need safety precautions, your call light in reach, assistance with ambulation, and move carefully. Hypercalcemia, your signs and symptoms and acne. So bone pain, arrhythmias, cardiac arrest, kidney stones, muscle weakness, excessive urination. This can be caused by an excessive intake of too much antacids with calcium. So you have different types of antacids. You have magnesium, aluminum, and calcium antacids. So when we talked about magnesium, we were specifically talking about magnesium-based antacids. Now we're talking about calcium-based antacids. Increased bone resorption of calcium. This happens in hyperparathyroidism, which secretes too much PTH, which is your parathyroid hormone. And then malignancy, so bone cancer, because the bone gets destructed by the cancer, and then the calcium within the bone leaches out into the serum. Increased absorption, thiazide diuretics. Thiazides, they can cause the retention of too much calcium. And then kidney disease. Kidney disease is pretty much with every hyper because it's decreased excretion. Treatment, you want adequate hydration to avoid stone formation. So when we're talking about stones, most renal calculi is caused by a large amount of calcium deposits. Okay. If due to excessive intake, you want to stop the calcium supplementation, avoid high calcium foods. If it's from increased absorption, you want to stop the thiazide diuretics, avoid high calcium foods, and then the last resort is for dialysis. Again, it says if there is a very large fall risk, your patient is at risk for pathologic fractures in both hypo and hypercalcemia, and you need to initiate safety precautions. Who takes a lot of thiazide diuretics? What disease process? It's pretty much your first line treatment for this disease. One of the most common. No, it's close. One of the most common diseases in the United States. Nope.
Hypertension.
Hypertension. First line treatment of hypertension, other than diet and exercise and lifestyle changes, are thiazide diuretics like hydrochlorothiazide. Questions about hypo versus hypercalcemia? All right, next is phosphate. The next couple ones, your biggest hitters, your most important ones, right off rip are going to be sodium and potassium. Those are going to be your very most top priority electrolytes. Next comes calcium and magnesium. Those are your second most important, okay? After that, it's like, yeah, these are important, but it's not going to kill you. You know what I mean? Like, it's going to make you probably feel a little uncomfortable when you have disruptions with these other electrolytes, but it's not life and death, okay? Sodium, potassium, life and death. Calcium, magnesium, severe enough, could be life and death. Phosphate? Nah. Is it important? Yes. Is it going to kill you? Probably not. Okay? So, phosphatemia, it's important for metabolism of carbs, fats, proteins. It's essential for acid-base balance, bone and muscle formation. Obviously, if you're extremely low or high in these things, yes, they can cause a lot of problems, right? Signs and symptoms. They have broken. B is for breathing problems, muscle weakness. R is for decreased deep tendon reflexes, so the reflexes are decreased. O, osteomalacia, which is weak bones. K, kills the immune system function. E, extreme weakness. N, neurostatus changes like irritability, seizures, confusion. Decreased absorption. This can be caused by decreased absorption, a lot of antacids, low vitamin D, excessive alcohol use, NG suctioning, severe malnutrition. So magnesium and calcium rise and fall together, right? Hypophosphatemia also has hypercalcemia. They are a teeter-totter. So your calcium and phosphate, if one is low, the other is high. And vice versa. So a lot of the things that you're going to see with hypercalcemia, you're going to see with hypophosphatemia. Oh, good. My antibiotics are ready. Yay. That's how I'm going to spend my lunch break. So for treatment, you want to supplement phosphate. You want to give with vitamin D to help the body absorb, because that also helps with calcium absorption, right? We need vitamin D for calcium absorption. And diet rich in phosphate foods. So patient is at risk for pathological fractures, again, due to the hypercalcemia. Hyperphosphatemia is the same symptoms as hypocalcemia because they are teeter-totters. The causes are a little bit different. Excessive intake of fleet or sodium phosphate enemas. If you don't know what a Fleet's enema is, it's you can buy them over the counter. It's a little bottle with a nozzle, and it probably has, I don't know, maybe 300, anywhere from like 200 to 500 mLs. I want to say it's like a 300 ml. I don't know. I've never actually bought one. I've only seen them in the hospital. And it's only meant to clean out the colon, like the actual like end of the rectum, the sigmoid rectum, because it doesn't go all the way up. It's a small amount of fluid, but they contain a lot of phosphate. Okay, so if you are using these often, your intestines are meant to absorb nutrients, so it's going to absorb the excess phosphate from the Fleet's enema into your system, which can cause hyperphosphatemia. Decreased excretion with kidney disease, increased absorption if you have vitamin D intoxication. Vitamin D is fat soluble or water soluble? Fat. What are your other fat soluble vitamins?
A, D, E, K.
A, D, E, K. Those are your fat soluble vitamins. You better know them. You better know them. Okay. Excess excretion into the blood, like chemotherapy, which kills the good cells. And then treatment would be calcium acetate. This binds to the phosphate in food before it can be absorbed, and you want to take these with food. So we usually call these phosphate binders. Reduce phosphate intake, reduce your use of enemas. If you need that many enemas, you need to see a physician. That's not normal. Okay. Restrict intake of phosphate-rich foods, and then your last resort is dialysis. Again, fall risk due to the pathological fractures. How do we regulate electrolyte imbalances? Electrolytes are gained by diet or medications. Oh, questions. Any questions on your electrolytes? Do you need to know them? Yes. Do you need to know the big ones? Yes. Do you need to know about pathologic fractures and EKGs and cardiac dysrhythmias? Yes. Foods that contain potassium. Uh-huh. Yeah. Yep. Any questions? Because now we're getting to the good stuff. And I really need you to pay attention to the next part. Okay. Now, like I said, this concept with acid-base balance is very important for you guys to understand. So, if you're truly not grasping, I need you to tell me. We need to talk. Okay? Whether it's in class, whether it's outside of class, because I need you to be able to survive the next 2 months, and you're not going to if you don't understand this. Okay? So, acid-base balance. The body's balance between acidity and alkalinity is referred to as acid-base balance. Okay? We have the lungs, we have the kidneys, and we have a buffer system. So, our body has two different ways of compensation when it comes to an acid-base imbalance. Your lungs are responsible for obviously breathing, right? And your kidneys are responsible for filtering, metabolizing the blood. So, the respiratory system compensates much faster than the kidneys, but it's not as powerful. The kidneys are slower, but they're stronger. This says they're slower, but mightier. Okay, so it's easy to breathe faster or breathe slower really quickly, which is why the lungs compensate faster. It takes longer for the kidneys to receive the message and to start doing things differently for compensation. Okay, so there are two abnormalities of acid-base balance. Acidosis, the blood has too much acid or not enough base, which results in a decrease in the blood's pH. Alkalosis, the blood has too much base or too little acid, which results in an increase in the blood pH. A pH that is below 6.8 or above 7.8 is usually fatal. Your patient will most likely not survive. Okay. Make sure you know these numbers as well as you know your children's names. A normal pH is 7.35 to 7.45. A normal PaCO2, which is the partial pressure of carbon dioxide, is 35 to 45. What did I say carbon dioxide was? Had you write it down.
Acid.
Acid. Acid equals carbon dioxide equals hydrogen ions equals ketones equals lactic acid. Okay? Your HCO3 is bicarb, bicarbonate. Bicarbonate, that is our base. So we have a base and we have an acid. Our normal bicarb is 22 to 26. The carbon dioxide is regulated by the lungs. The bicarbonate is regulated by the kidneys. So, acidosis. I told you there was a relationship between hydrogen ions and potassium. Okay. So if you have too much hydrogen, which I told you acid equals hydrogen ions, you will have acidosis. What will happen to your potassium? I know you've been on your phone the whole time. I see you, girl. Okay. So, too much hydrogen, it would go down. Hypokalemia, a cause of hypokalemia is, oh my God, hold on. Hold on, I don't want to say it wrong. I need to make sure it's right in my brain before I say it. So, when you're in an acidotic state and you have a lot of hydrogen and the outside of the cell, extracellular hydrogen, the cell is going to try to compensate by saying, hey, if I give you potassium, give me some of your hydrogen. So it's going to try to neutralize in that way because it's one for the other, right? Which is why it says, consider your potassium level. Okay. Heart excitement, arrhythmias, EKG changes, hypotension, thready pulses. This is your, this is how your patient is going to look when they're acidotic. Okay. They have a risk for arrhythmias, EKG changes, depression in the CNS function. There's a headache. They're confused, lethargic. They have muscle weakness bilaterally, changes in breathing, which is your Kussmaul respirations. We're going to talk about those a lot next week with DKA. Kussmaul respirations are deep and rapid. Okay. Skin changes, warm, flushed, dry skin. If it's metabolic, pale to cyanotic and dry skin if it's respiratory. And then GI, you can see nausea and vomiting. So there's 4 when you talk about acid-base imbalance, there's either acidosis or alkalosis. On both sides, you will either see metabolic or respiratory. So you can see respiratory acidosis or metabolic acidosis. You can see respiratory alkalosis or respiratory alkalosis. Okay. It's going to be caused by something, whether it's respiratory or metabolic. The compensation will come from the opposite of what it's caused by. So alkalosis is too much bicarb or too little hydrogen. You're going to see increased activity, anxiety, irritability, tetany, seizures, hyperreflexia, cramping, twitching, tachycardia, increased respiratory rate, not Kussmaul, not those deep breaths, those deep rapid breaths, just increased respiratory rate with respiratory alkalosis. Next to this, respiratory alkalosis, I want you to put a hyphen and write hyperventilation. So we've all hyperventilated before, yes? You're crying and you can't catch your breath, right? Going snotty. You can't breathe. Well, you can breathe. You're just breathing rapidly and you can't catch your breath and you can't stop it. It's because you've put yourself into an alkalotic state. You have sent yourself into respiratory alkalosis. Okay? Now remember, I told you that carbon dioxide is your acid. So if I'm breathing rapidly, what am I breathing off? All of my CO2. I'm letting go of all of my CO2 because I'm breathing so rapidly. If I don't have enough acid, I become alkalotic.
So is that why they have some people use like a brown bag or something to try to breathe it back in when they're breathing out too fast?
Yes, ma'am.
Gotcha.
So your easiest treatment for respiratory alkalosis, I don't know about you, but I don't carry around a paper bag all the time. I don't have one in my purse, but I do have hands. And I can breathe into cupped hands because I need to rebreathe my CO2. Okay. So on the flip side, I just had surgery and I took 2 oxys instead of 1 because, man, I'm hurting and I need to sleep. I'm laying there on my couch and then all of a sudden, I have a respiratory rate of like 8. And I'm not very arousable. What am I retaining? CO2.
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 I'm retaining CO2. That is respiratory acidosis. Hypoventilation. That's one very common cause of respiratory acidosis. The next most common cause, if not equal to or more, would be COPD or asthma. Any type of restrictive airway disease. Because what happens with COPD and asthma? We get what's called air trapping. And the carbon dioxide gets stuck in the bases of the lungs and we can't get it out. Okay? You ever see a patient with COPD exacerbation? They're pissed.
Yep.
They're pissed. They are not themselves. They're confused. They are angry, agitated. And then eventually, when the acidosis becomes even worse, they can become somnolent and even comatose because of the carbon dioxide trapping, causing respiratory acidosis. Okay, so how do we fix that person? We can't just say, hey, breathe faster.
Isn't one of them like pursed lip breathing?
Pursed lip breathing, yes, but that's in the very beginning. That wouldn't work for someone that's in a bad exacerbation and really trapping a lot of air. The answer would be BiPAP. Okay, BiPAP.
Yeah, my grandma had to be vented and eventually had to get a trach because hers got so bad. She was in a coma for like a month, pretty much.
Yeah, that sucks. I'm sorry. BiPAP is bi-level positive airway pressure. CPAP is continuous positive airway pressure. So CPAP, for your patient that has obstructive sleep apnea, this is continuous air that's just shoved into their mouth or nose, keeping their airway open. BiPAP is I'm shoving air in to make you breathe, but I'm also forcing air out to get rid of your excess CO2. Is that starting to make a little bit of sense? A little bit?
Yes,
Okay.
a lot.
Good. Okay. So, diagnostic assessment, when we're talking about acid base, number one, our gold standard is going to be an arterial blood gas. After that, we can use chemistry like our BMP or our CMP that gives us electrolytes, kidney function, liver function. A hemoglobin can never hurt, and then a lactic. Remember, I told you acid equals lactic acid because too much lactic acid can cause acidosis. Okay. All right. Now, I say we have a short lunch, 20 minutes, that's it. And then we come back and we work on this. Okay, let's come back fresh with our tummies full, antibiotics ingested, and let's start doing ABG interpretation. How do we feel about that?
Miss Simmons, do you think
Sounds good.
will be done by like 12:45? Because I have to drive from Michigan to Ohio, and I don't want to like miss when we're doing the worksheet. So I could be writing stuff down.
Unfortunately, no. But this is recorded and I am going to be posting it.
Okay. All right. Thank you.
So unfortunately with the with the ABG and like worksheet situation, obviously you can't do that while you're driving. You can listen. You can listen while you're driving. Which is fine. You can go on Ring Central, from your phone while you're driving. But otherwise, I am going to try to get the video uploaded tonight.
Okay.
Depending on when it's available. Sometimes sometimes it's not available till like the middle of the night, and then it'll be tomorrow morning.
All right.
Okay.
Thank you.
You're welcome. All right, 20 minutes. We're gonna need it in here. Okay, 20 minutes. Are you guys all on Room Central in front of you? I'll share from my screen again. I can't. I'll do that.
When is the age worksheet due?
Sunday.
Okay, thank you.
Yep. Are you all drugged up? No, I didn't take my drugs yet. They're in the bag. I know, right? The pharmacist, she goes, it wants me to tell you that you can have, and I'm like, QT. She's like, yeah, QT Pro. And she's like, wait a second, how do you know that? It's like, I'm a nurse. It's fine. I know that it increases my risk for a prolonged QT. I promise I won't take it with Zofran. It'll be fine. I'm getting there, I promise. Yes, it's me. Love when my computer doesn't recognize me. I love technology. Okie dokie. Okay. Okie dokie. So when we talk about ABG interpretation, there's a couple steps. Step one, there are two widely taught methods to interpretation. I like the tic-tac-toe method. It's the method that I teach. There's also something called the Rome method. And I'm going to give you like a little helpy guide thing that I'm going to post on Brightspace. And if you find that you like the Rome method, I don't care how you do it, as long as you get the correct answer, whether it's tic-tac-toe, whether it's Rome. But I will be teaching tic-tac-toe. Okay? So, number one, you want to complete the tic-tac-toe board. Now, like I told you, you need to know these numbers as well as you know your children's names. Okay? What is something significant about the CO2? The numbers in front of you. They're backwards.
Yeah.
They're backwards. It's not 35 to 45, it's 45 to 35. That's on purpose. Okay? Do not forget to flip them. So your pH 7.34, or this is supposed to be 3.5. 7.35 to 7.45. Your CO2, your normal CO2 is 35 to 45, but when you're interpreting, it's flipped. Do not forget it. And then your bicarb is 22 to 26. The only one that is different is your CO2. It's flipped. Okay? So step two, you want to determine, is your pH acidic, alkaline, or normal? So the middle of your tic-tac-toe is normal. To the right side is alkaline. To the left side is acid. Okay? And then is your CO2 or bicarb high or low? Okay? So I have an ABG. My pH is 7.39. Is that high, low, or normal? That is normal. My CO2 is 38.4. High, low, or normal?
Normal.
Normal. My bicarb is 22.6. High, low, or normal?
Normal.
This is a normal ABG. Hallelujah. Yay, we're alive and wonderful. Okay? So our interpretation, woo. Okay? All right, so my pH is 7.16. Low. So what's that? Where does that fall?
Acidic.
Acid.
My CO2 is 45.
Normal.
Also acid. Oh. Below
My
45.
bicarb is 16.
Acidic.
Oh. Okay. So now is where we distinguish if it's respiratory or metabolic. Okay. So I want you to look at this like a weight system. Okay. I have no weight here. I have one plate here and I have two plates here. So my heaviest side is my acid side. Yes. What else is on my acid side?
Metabolic.
Is my bicarb. My bicarb is associated with metabolic or respiratory. Metabolic. So this is metabolic acidosis.
Can you explain that again?
Yes.
Yeah, I was gonna say, can you explain the metabolic part again? That was a little confusing.
So multiple slides ago, we talked about how CO2 equals lungs and HCO3 equals kidneys. That was like one of the first couple slides. Okay. Your lungs control your respiratory and your kidneys control the metabolism. If this was respiratory acidosis and it was the same type of situation, then yes, the CO2 would be in the acid and the bicarb would be normal. If it was the same exact situation, just respiratory. Okay. So on the acid side, I have 1, I have 2. I got nothing over here. I got 1 here. So if I'm looking at this as a weight system, this side is winning. I got heavy stuff over here. So that means I have acidosis and it's being caused by the kidneys. Okay.
Miss Simmons, why would you put the CO2 in normal instead of the acid side?
Because 45 is normal.
Okay, so just because it says 45 with the arrow, that's just, so if it was 46, it would go there.
Correct.
Okay, got it.
Correct. Okay. Now we're going to start making it a little more complicated. And you're like, but Jessica, it's already complicated. I know, I'm sorry. But it's going to get more complicated. So now we're going to talk about our first rule of compensation. Compensation rule number 1, if pH is abnormal and CO2 or bicarb is normal, then the ABG is uncompensated. Okay. So my pH 7.49, is that normal? No.
No.
That would be on what side?
Alkalotic.
Alkalitic.
Okay. My CO2 is 30.6.
Normal.
Is it?
No, it's not.
Alkalotic.
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 Okay. And my bicarb is 25.
That's normal.
So my interpretation is that this is see, now I can't spell. Uncompensated respiratory alkalosis. So when we talk about compensation, remember I told you the lungs work very quickly. The kidneys, they take a couple hours to a couple days to start compensation. Compensation is our body's way of trying to get back to homeostasis, right? To get back to a normal place. So if my respiratory is all whacked out, I told you what causes respiratory alkalosis. One of the most common causes of respiratory alkalosis.
Hyperventilation.
Hyperventilation. Hyperventilation. If my kidneys were trying to fix this, my kidneys would be abnormal. But because they're still in a normal range, there is no compensation that has occurred yet. It is uncompensated. Okay. So there's 3 concentration rules. If the pH is out of range and the CO2 or bicarb is in range, either one, it is uncompensated. If all 3 are out of range, that is partial compensation.
Would the bicarb move to the alkalytic side or the acid side?
If my body was trying to compensate, I wouldn't want my kidneys to produce more bicarb because that would make my body more alkalotic. I need balance. So it would go to the acid side to compensate. Okay. If my pH is normal, we are fully compensated. If the pH is normal and both my bicarb and CO2 are abnormal, it's fully compensated. If my pH is normal and one of them is in range and one of them is out of range, it is compensated. Because that means my body has compensated enough for my pH to normalize. I'm just waiting for the other 2 to catch back up. Because the goal has been like 90% achieved. My pH is now normal. Yes. And now my CO to fall back in line. Okay. So I have a pH of 7.56.
Alkalotic.
My CO2 is 38.
Normal.
My bicarb is 35.
Alkalotic.
What is my compensation?
Uncompensated respiratory alkalosis.
Uncompensated
Metabolic alkalosis.
metabolic alkalosis. Yes.
Okay, just to make sure I'm not confused, the only way it's not the only way it is compensated is if your pH is normal.
Correct.
Okay.
In order to have full compensation, the pH must be normal. It must. That is the rule. All right, so my pH is 7.45.
Normal.
Why are you confused?
The first one we did, CO2 was in normal pH. Yeah, it wasn't. It was just metabolic acidosis.
Well, that's because we didn't get to compensation yet. Those first couple ones that we did, we didn't go over any compensation yet. So that's why I didn't put it in there. Yeah, we're building. We're building blocks. I can't just hit you with compensation right out the gate. We got to talk about metabolic versus respiratory first. All right,
I
so
think that's where I'm confused. Like, I totally understand the compensated, uncompensated, but how do we know if it's metabolic or respiratory?
okay, we're gonna keep going.
Okay.
And we're gonna so my pH is 7.45. We said that's normal. So I already know whatever happens here, I'm fully compensated. I already know because my one rule for full compensation has been met. Whatever else happens, I know that I'm fully compensated, right? My CO2 is 21. My bicarb is 12. Now, this is a very important rule. This is called the rule of 4. I'm gonna give you a tip sheet that has all of this information on it, and you're going to find it very helpful, I promise. So this is called the rule of 4. Okay, so we know that this is supposed to be 7.35, right? So middle here is 7.4, right? That's the middle of my pH. My normal range of pH is 7.4. So my pH here is 7.45. On this range, is it going more towards the alkalotic side or the acidotic side?
Alkalotic.
So it's on the alkaline side of normal, right? It's normal, but it's leaning towards the alkalotic side. Yes? Okay. Which means yes, yes, which means it is fully compensated respiratory alkalosis. Because which way is my weight the heaviest? It's this way. You know the little weight thing? Right? Think about it like that. So I have a little weight, right? This is alkalosis. This is acidosis. Which side is heavier? Right? If my 7.45 is leaning towards my alkaline side and I have my CO2 over here, then this side is heavier.
Tic-tac-toe is one of your assignments?
Yes,
Kind
it is.
of.
Yes,
It's
it
actually
is,
called
sir.
the tic-tac-toe chart.
Tell him, Hannah. You tell him. You tell him, girl. Yes, it is part of your assignment. What do you think you're doing?
Sorry,
Just playing games?
He
We
just
are not
happened to
playing
look
games
and
here,
see
sir.
the tic-tac-toe board.
I'm just kidding. I'm just being funny. I'm just being funny.
Oh,
Okay.
I'm sorry.
Does
Okay,
this
I have a
make
question.
sense?
I'm sorry.
Yes, go ahead.
What if that was just 7.4? So if your pH is 7.4 and your CO2 was the alkalytic side and your bicarb
So
acid
thankfully, I will never ask you that question. Because that's where things get very, very complicated. And that is we can let our physicians handle that side of when things get really complicated. Okay? Exactly. That sounds like a doctor problem. Because if it literally is 7.4 on the dot, I will never ask you to do a problem like this and give you a pH of 7.4. Never in my life. That is just rude. Because that's what it makes it too difficult for us to interpret. Okay? I don't know which side is going to take up. It's not leaning either way. How am I supposed to know? I don't know. Right? So I don't expect you to know. Does that make sense? Is that an acceptable answer?
Yeah. So
But
then if
isn't it
Go ahead.
I'm sorry, Amanda. So if it's 7.35, it would be metabolic. Instead of it saying it's the fully compensated respiratory alkalosis, it would be
If this was
metabolic acidosis.
7.35,
Right.
like the whole question was backwards. If this was 7.35,
Yes.
then this would be fully compensated metabolic acidosis.
Okay. Okay.
Does that make sense?
Yeah, it does.
Okay. All right, my pH is 7.1.
Acidic.
Acidic.
My I'm sorry, my CO2 is 73.
Acidic.
My bicarb is 25.
Normal.
Okay. So look at your compensation rules.
Uncompensated respiratory.
Uncompensated respiratory acidosis.
Acidosis, yep. I won't lie, this is a tiny bit fun, just a tiny bit fun.
I know, I love it. I love it. Okay. I am so nerdy. I love this stuff so much, guys. Like it's wait till we get to cardiac. Like it's just I just love it. All right. So now, what did I tell you were the two most common reasons for respiratory acidosis?
Hyperventilation?
No, other way. Other way.
The CHF and
Hypoventilation
asthma.
caused by what?
CHF and asthma.
COPD.
COPD. That's what I meant.
Or just restrictive airway disease. And what was the second one?
Was that respiratory distress?
Overdose.
Overdose.
So like when the patient is about to be intubated, is this what they see when they draw that ABG? Like is this kind of what those numbers will look like?
If the patient, yeah, I mean, depending on the cause. So you have to think about the cause. So is your patient experiencing a COPD exacerbation or let me put the overdose, over sedation? Okay. So is your patient in this situation where they're hypoventilating? And you draw an ABG and you say, wow, this patient is uncompensated respiratory acidosis. The physician is looking at this patient and saying, we need to intubate. We need to protect this patient's airway because if we don't, this patient is going to die. This patient can no longer protect their own airway. and we need to resolve our acid base imbalance, then yes, the answer to your question would be yes. All right, we have a pH of 7.35.
Normal.
Okay. Normal. My CO2 is 55.
Acidic.
My bicarb is 32.
Alkalotic.
So what do I need to do?
Is it fully compensated?
Yeah,
It's
it's
definitely
compensated,
fully
but it's
compensated.
leaning more towards the acidic side.
Respiratory acidosis. Yeah.
Yeah.
So fully, I told you would get it. Fully compensated. Now, don't be surprised that later on when you go to do this, because right now at the end of class, you're going to be like, wow, that makes all the sense. This is so cool. I totally understand this. And then later tonight, you're going to look at this and be like, I have no idea what this is. And it's going to be
Wait, I have
right
a
out your brain.
question.
Yeah.
So on this question, the normal, like above the, next to the arrow, it's 7.34, but it's supposed to be the 7.35.
Yes.
So if we do this pH 7.35 as normal, 2 slides ago we had 7.45 and we put that as normal as well. Oh wait. Never mind. I answered my own question.
Perfect. I love this. Answer your question. But
Can you please go over this one? Because I understand the fully compensated part, but the rest, the respiratory, and I don't understand.
so this is your rule of 4. Remember we just talked about the rule of 4 and the weights.
So are the weights separate? Like, am I looking at a different weight for the CO2 and a different weight for the bicarb?
No. No, no, no. No, ma'am. No, no, no. No,
Okay.
no, 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 no. 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 So in this question specifically, I have a bicarb over here. I have a CO2 over here. The middle of my pH is 7.4. My pH is what? What is my pH?
7.35.
7.35, which goes this way, which is going to cause my weight to be heavier over here.
Oh, okay, that makes sense. I don't think I picked up on the arrow that way. So whatever way the pH is leaning.
Yes.
Okay. Thank you.
Yes. Yeah. Yes. 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 Kaylee,
Got
does
it.
that make
Thank you.
sense?
Yes, yes.
Okay.
The pH is like the tiebreaker.
Yes. Yes.
Okay, thank you.
Absolutely. That's a really good way. John A, do you have a question? I don't usually
Yes,
see
ma'am.
that little hand thing. So,
Sorry, I didn't want to yell and like cut somebody off. I'm sorry.
oh no, you're totally fine. I just happened to see it. So if I don't see it, I don't want you to think that I'm like ignoring you, but go ahead.
Oh no, it's okay. I just put it up.
Oh,
So
okay.
if the bicarb was in the acid and the CO2 was in the alkalotic, would it become metabolic acidosis?
Wait, say that again.
If the pH was still 7.35 and the bicarb was acidic and the CO2 was alkalotic, would it make it fully compensated metabolic acidosis?
Yes.
Okay,
Yes, ma'am,
okay. I
it
just
would.
wanted to make sure I was understanding it right.
Yes. Yes, yes, yes. Okay. pH is 7.16.
Acidic.
My CO2 is 70.
Acidic.
Acidic.
My
They're all
bicarb
acidic.
is 11. Ugh, I hate these ones.
Acidic.
Okay, so we're gonna go over this, But what I want to say is that I will never put one like this on your test. Okay? Because just like we talked about the whole 7.4 thing, this is also way above our pay grade. Okay? Because what's happening here is it wants you to, how do I want to say this? First of all, what is my compensation?
Partially compensated.
Partially compensated. This is partial compensation. But how the F am I supposed to know, is it respiratory or metabolic? I don't know. They're both on the acidic side. I know it's acidosis. I know something's wrong with my acid, right?
Is it because the CO2 is more abnormal than the bicarb?
It is very yucky. And I will never test you on one of these.
Let's sit here with all those ones with the fully compensated that are playing with numbers, taking the pH out of it. And the one that has the greater gap from the normal, either high or low, seems to be what it is.
I don't want you to follow that rule. That's not a rule.
No, but
it may be a coincidence. Right.
But
That's what I'm saying. It may be a coincidence or a pattern that you're seeing, but I want you to make a difference in your brain. The pattern is not the rule. So don't make that a rule in your brain and then you get all screwed up. You know what I'm saying?
Wait, so I have a question.
No, I'm not doing that next one. I'm doing the next one. Go ahead.
So if I am allowed to ask, when we do take our exam, it's not gonna be a tic-tac-toe like this, but you will give us like this information and then it will be like a multiple choice question. Basically, we have to pick like which interpretation it would be.
Basically, yes. So what's going to happen is there's multiple different ways that I can ask these questions. So I could say your patient has the following ABG. What disease is most likely the underlying problem? And if I give you something that is clearly respiratory acidosis, and one of your options is COPD, you bet your bottom dollar that your choice, that the answer is COPD. Okay? So that is something that I really need you to connect in your noggin. What causes what? Okay? Number two, hold on. Number two, I can say, interpret the following ABG, just like this. pH is 7.36, CO2 28, bicarb 12. And your options will be metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. Okay? Number three, I can say, interpret the following ABG, blah, blah, blah. Partially compensated respiratory acidosis, compensated metabolic alkalosis. Okay, there's many ways to ask these questions, and I need you to be prepared for all of those ways.
can you give us a cute little tic-tac-toe board?
Okay, so I get that part.
You have a whiteboard that as soon as you hit start on your exam, because we're not allowed to write things before the exam starts, you have your whiteboard, you have your pen, and as soon as you hit start, you write your tic-tac-toe, you put 7.35 to 7.45, 45 to 35, 22 to 26. And that is the only, that's just that. Now go ahead, what were you gonna say?
Yeah, I was saying that I get what you're saying, like understanding like why it's happening, like why they have respiratory alkalosis or acidosis. And I get for the respiratory part, but if it was like metabolic acidosis or alkalosis, like what would be some of the reasons why they would have that?
That's a great question. That's a very good question. Okay.
Miss Simmons,
Yes.
I sent you a private message. Can you let me in on my phone, please?
Oh, yeah. Sorry.
It's okay. Thank you.
So, what else did I tell you equals acid?
Lactic acid?
Lactic acid.
I don't know.
What is a medication? You probably won't remember this.
You told us in farm and I forgot it, but you did tell us in farm.
I know I did. And I just got done teaching farm, so it's like really fresh in my brain. A very common drug that can cause metabolic acidosis by a buildup of lactic acid is metformin. Metformin can cause rhabdomyolysis. Rhabdomyolysis is the breakdown of muscle tissue. And that breakdown of muscle tissue can cause a buildup of lactic acid. That buildup of lactic acid can cause metabolic acidosis. Everything I told you was equal to acid. Ketones. So do you think diabetic ketoacidosis causes metabolic acidosis? Yes, ma'am, it does. Yes, ma'am, it does. We don't have any boys in here, right? We're all gals? I'm pretty sure I don't have any boys. So I can say ladies. I don't have to say ladies and gents. My last class had a couple boys. So diabetic ketoacidosis, it's literally in the name, right? Causes metabolic acidosis. Now, metabolic alkalosis is going to be caused by either the kidneys retaining too much bicarb or the kidneys not releasing enough hydrogen ions. Because remember, the lungs can breathe out CO2. Can your kidneys release CO2? No. There's no CO2 in urine. What can it release? It can release hydrogen ions. Make sense?
Yeah, so would it be
What
like
did
a
you-
specific disorder they would have that could go with that?
For respiratory alkalosis? Or I'm sorry,
No, for the
metabolic alkalosis?
metabolic, yeah.
Sorry, I got tongue twisted.
So it would be like DKA and then
That's acidosis.
okay.
I'm
she was
talking
saying
about metabolic alkalosis. So, metabolic alkalosis is caused by an excess of bicarbonate, or loss of acid in the blood. This is often driven by vomiting, gastric suctioning, diuretic use like loop diuretics and thiazides, hypokalemia, and mineral corticoid excess. That is I'm sorry. Come on, Jess. Addison's. Or is it Cushing's? Excess, mineral corticoid excess. That's Cushing's. That's Cushing's. So metabolic alkalosis can be caused by vomiting. Somebody put something in the chat. Oh, Marissa, I remember. See, now it's all coming back to me. Marissa loves to share things in the chat, and I love that. Metabolic alkalosis causes too many antacids, yes. Diuretics, yes. Excessive vomiting, hyperaldosteronism, yes. Metabolic acidosis causes DKA, AKI, malnutrition, severe diarrhea, yes. Agreed. Add to that list metabolic acidosis also caused by rhabdo and lactic acidosis, lactic acid. Are we ready to keep going?
No, I had a question. How do you decipher between partial compensation and uncompensated?
You got to go back to your compensation rules. Uncompensated is when the pH is out of range, but the CO2 and the bicarb is in range. In order to be partially compensated, all three have to be out of range, which means the whole middle of the tic-tac-toe is open. There's nothing written in the whole middle of the tic-tac-toe. Nothing.
Okay, thank you.
Okay. Oh my God, these pills are gigantic. Look at this thing. You see how big that thing is? That's a horse pill. Augmentin. I have the pages for these from my nurse in the making book. I'll send to the group email. It's all side by side and helps a lot. Also has the Rome method. That would be wonderful, Marissa. I'm sure your classmates would appreciate that. I know one of my girls in my class is looking at it too. Is that the book you have? Nurse in the Making or something? Nursing School Success Bundle. All right, let's keep going. Yes? So we have a pH of 7.36. Huh? Normal. So I already know off rip. I'm what? What's your phone down?
Fully
Fully
compensated.
Fully compensated. Unless it was emergent.
I just looking. I was reading stuff about this.
So were you?
Yes.
Was it helpful? What was it? I just yelled at her to put her phone down.
It was about the balances the acid and the pH.
Well, I'm sorry I interrupted you.
That's all right. So pH.
pH is normal. All right, CO2 is 28.
Alkalotic.
My bicarb is 12.
So this would be
Acidic.
fully compensated metabolic acidosis.
Yes, baby. Do you feel better? You feel good about it?
Yeah.
Is anybody completely lost? I promise you, if you are not alone. I'm telling you right now, there is 42 people in this class right now. I promise you, if you are not understanding, you are not alone. Please tell me.
I have one question. I'm sorry. I feel like I
Go
just
ahead.
lost everything you said. Like I got that it was fully compensated because the pH is normal, but what makes it metabolic instead of respiratory?
Is it
See my weight?
because
See my weight?
the
Oh, because it's closer to the 7.45. No, wait.
Yes.
Oh, wait, because it's lower than the 7. Okay, never mind. Never mind. I got it.
That makes sense?
I mean, I wrote
Don't
that down
forget.
because I answered this before you started it, but I couldn't remember why.
Oh, okay. So, and
I drew a
guys,
blank for a
draw
second.
draw your little weight system. Right? I got CO2 here. I got my bicarb over here. 7.4 is in the middle. So my pH is 7.36. So that means it's leaning this way, making this side heavier. Right?
I get it. I just keep getting confused. It's okay.
That's okay. Listen, I'm telling you right now, you are going to have moments in these next couple weeks. You are going to have moments, specifically in this first week, where you're like, oh my God, I get it. And then the next moment you're like, I don't get it. And when you think about practice makes perfect, I'm telling you, this is where it's at. Practice makes perfect. And sometimes I still screw it up, which that pisses me off. You know, I don't like when I'm wrong. So 7.59.
Alkalotic.
Alkalotic.
CO2 is 25.
Also
Alkalotic.
alkalotic. So they're all alkalotic.
Peace. Stupid. All right, I think I want to pull up the worksheet.
Yeah, this one's on the worksheet, so was that other one, but I've just been like kind of following along and Xing them off as you've said that.
Good. And that's harder to see. All right, we're gonna go to page 5. Let me know when you get there. I gotta stop avoiding this pill. Just take it. Hmm? Are you talking to yourself back there?
Yeah.
All right. What are my normal ranges? I want to write that at the top of my paper. Where's my pen? It never.
Take the pH and get rid of 7 and you flip it for the CO2. So like 7.35, 35 is on this side with the CO2. So if you just get rid of the 7 and the period and you flip them, that's the CO2 and you grade out. That makes sense.
What is what's my normal CO2?
It's back.
35 to 45.
But it's backwards. Don't forget it's backwards. What's my normal bicarb?
26 to 22 because it's backwards.
No, my bicarb is not backwards. Only the CO2 is backwards.
Oh shit.
Only is backwards. Okay. All right. I have a pH of 7.16.
What do you have like?
My bike or my CO2 is 45. Huh? It's normal.
Oh.
My bicarb is 16.
Acidic.
Okay, so what's my compensation?
Uncompensated.
Okay. Respiratory or metabolic?
Metabolic acidosis.
Yes. All right, 7.56.
Alkalytic.
CO2 is 38.
Normal.
My bicarb is 35.
Alkalotic.
What is my compensation?
Uncompensated metabolic alkalosis.
Does everybody understand how we got those first two? They're basically the same, they're just opposites. Yes? No? Yes, Jessica. Got it. Okay. pH 7.45.
Normal.
CO2 is 21.
Alkalotic.
Alkalotic.
My bicarb is 12.
Acidic.
Compensation?
Compensated. Respiratory alkalosis.
Do we understand why it's respiratory?
It's a high
Because
side
the
of the
carbon's
pH
normal.
is leaning more towards the alkalytic
Because
side.
it's leaning toward, yes. Yes. Okay. 7.10.
Acidic.
CO2 is 73.
Acidic.
Bicarb is 25.
Normal.
What is my compensation?
Uncompensated respiratory acidosis.
Is there any in particular that you're having a hard time with? That you want to do maybe more of? Or do you just want to keep going?
Keep going.
Okay. All right, 7.35.
Normal.
Normal.
55.
Acidosis.
32.
Alkalytic.
Alkals.
What is my compensation?
Fully compensated respiratory acidosis.
Yes. 6 and 8 were the ones you crossed out. Okay. All right, number 7. pH is 7.36.
Normal.
Our CO2 is 28.
Alkalytic.
Bicarb is 12.
Acid.
Compensation?
Fully compensated metabolic acidosis.
Yes. All right. No, that's the last one. And then number 8 is another one where it's all on the same side. So okay.
Kaylee asked if you could let her in on her iPad.
Yeah. I don't know. Oh, there she is. Okay. So I'm gonna upload. Okay, so this is a ABG interpretation and compensation guide. It gives you your normal ranges. We don't really need to worry about the PaO2 or SaO2 yet. That's gonna come in 2852. It gives you your step-by-step. So step-by-step ABG interpretation, you need to check the pH. Number 2, determine the primary cause. Number 3, check for compensation. Number 4, like I said, we're not doing that yet until complex care 2, where we're talking about oxygenation status. Next, there's the 3 levels of compensation. Here you have the rules for compensation. Okay. And then at the bottom, it's your Rome method. If you find that the tic-tac-toe doesn't really do it for you. I always have a couple random, like outliers of my students. Most people like the tic-tac-toe, but there's always a couple that really like Rome. So look at the room, see if it makes more sense to you, if you like it. If it doesn't, leave it. If it does, use it. Okay? Whatever you want to do. We actually got through everything, which is crazy. Is there anything else in the PowerPoint? Yeah.
Yeah,
The blood transfusions and stuff.
I'm like, we're done. That's the thing. Oh, Jesus. Yeah. Wait, what?
This whole packet of papers.
Yeah.
Osmosis and diffusion on that.
There's only like 7 slides left, I think.
Yeah. Yeah. I mean, it has like a lot of helpful stuff on there, I think.
She's making her. One thing I also get.
Okie dokie. Back to, do we need a 5-minute break? Okay, 5 minutes, no more. I always say that and I'm the one that's late. Don't you love that?
It's part of our. Well,
Is
they're
that-
going to print. Huh. But it's like 7 slides.
Oh my God.
We can't hear you.
I never unmuted myself. Thank you. That would have sucked. Okay. So a single unit of blood contains 450 mLs and 50 mLs of an anticoagulant. Each type of blood component is stored differently based on what it is and how it needs to be stored. This little box is very important. Okay. Blood transfusion facts. Blood can only be initiated by a registered nurse. Only, hear me, hear my words. Only normal saline can be used with blood. Never, ever, 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 ever use another type of IV solution with a blood product. Never. Number 3, the type and screen is good for 72 hours. Because, why is that? It is because we build antibodies. So a type and screen has to be redone after 72 hours in case that person has received many, many blood products and has new antibodies. Number 4, the blood must be started within 30 minutes from the time it is picked up from the blood bank. These are universal rules, by the way. And number 5, blood must be transfused within 4 hours of starting. Now, if you tell me, but Jess, there's only like 10 mLs left in the bag and it's going to be 5 minutes over. No, ma'am. Throw it away. It has to be infused within 4 hours of starting. That is the rule. These rules, these are not facility-based. No. Because remember, facilities have different rules about blah, blah, blah. No. These are blood transfusion facts in the entire country. These are standard blood transfusion facts. Okay? No facility protocol will ever void any of these facts. Understood? Okay. Blood compatibility. This is what people struggle with the most when it comes to blood transfusions, is blood compatibility. So, you guys just got out of OB, you learned about the RH factor, right? So, my blood is either negative or positive, right? For example, I am O negative. Okay, so I have a negative, not have to receive Rogaine while I was pregnant. Okay.
But you're a universal donor then.
I am. And you know what's very sad? I do not donate. I get too many tattoos. You can't donate if you've gotten a tattoo in like the last year or something. That like totally X's me out. Like I'm not even a candidate to give blood. Also, I'm kind of a jerk. I've never done it. It freaks me out a little bit. I know that we need to. I know that I should. I don't know, it freaks me out. Anyways, if your blood has the Rh protein, you will have a positive blood type. If your blood type does not have the protein, you have a negative blood type. So, when we talk about compatibility and the blood compatibility chart, you have O negative, who is the universal donor. That is me. Okay? Then you have AB positive, who is the universal recipient. So I can give blood to everyone AB positive can receive blood from anyone. Okay? If I am O positive, I can only have O positive or O negative. That's it. You can't give me A or B because those are antigens. And my body will attack them because they're foreign. I don't like them. Okay? If I'm A positive, I can have O positive because O is not an antigen. It's the lack of an antigen. So I have neither A or B, which makes me O. Does that make sense? So I am the lack of an antigen. So if I'm A positive, then I can get O positive because it's just a positive protein with no antigen. I can get O negative because that's the universal donor. I can get A positive because that's my blood type. I can get A negative because A is my antigen and I already have a positive protein. So if you give me something with a negative that has no protein, it doesn't matter. It's not going to harm me, right? But everything changes when I'm A negative. If I'm A negative, you cannot give me a positive. No, no, no. No, no, no. If I'm A negative, I can only receive O neg or A neg. So when you are in the negative group, you're more limited. Like me, I'm O negative, I'm screwed. I can only receive O negative. I can give it to everyone, but I can. Okay. So the negative people, they're kind of screwed. When you look at A positive and B positive, they always have 4 options. They can receive either one of O. I can receive O. Give me all the O. O positive, O negative. I can have it. I can get what I am. I'm B positive. I can get B positive. And I can get my B antigen without the protein because that's not going to harm me. My blood's not going to attack that. So my A positive, my B positive, I got 4 options here. It's a nice amount of options, right? My A negative and B negative, I only got 2 options. I can only get what I am or the universal donor. So I have less options. AB positive, I can get it from anybody. Love that. AB negative, because I have 2 antigens, my A and B, it's just like combining this B negative and A negative. So I have 4. How confused are you?
Actually, you're very limited. Anything after that, you got more options.
If you're A negative and you need blood, you're screwed. Not really. There's a lot of O negative donors, thankfully. But this is why a cross and match is so important. Yes, do we give O negative for traumas when we need blood really quickly? Yes, of course, because we need to save your life. 2:30. Okay. What did I just say?
Negative traumas.
Oh, when somebody comes in as a trauma, we're going to give them O negative because we need to save their life, right? But as soon as you're crossed and matched, there's no longer just dumping O negative into somebody. You're crossed and matched so you can have the best match that we can find. That's the whole point. And to decrease the amount of transfusion reactions, which can be really scary and life-threatening. Okay? I do need you to understand this chart. Okay? Okay, there's a couple different types of blood products. We have whole blood that includes red blood cells, white blood cells, platelets, and plasma. This is not the most common because I don't want other people's white blood cells. That's like heavy into their immune system and like their immune response and their stuff. Like, I don't want all that. If you have to give it to me, then yeah, give it to me to save my life. Whole blood is not the most common thing that you are going to give as a nurse. The most common thing you are going to give as a nurse is going to be packed red blood cells. Because this is going to be for acute blood loss, anemia, acute anemia, where you're replacing the red blood cell itself. Okay? Not all of the other components that go along with it. So the packed red blood cells replace your red blood cells. And this is for anemia or an active bleed. This is active GI bleed. That's one of your most common active bleeds is GI, but it can really be for any bleed. Then you have platelets. Obviously, platelets deal with coagulation, right? Prevent bleeding. And these are given to people that are thrombocytopenic, which means they have low platelets. Okay? Fresh frozen plasma. This is for rapid volume expansion and clotting factor deficiency. If your patient is receiving multiple units of packed red cells, you're probably going to be giving at least one bag of plasma, just to kind of dilute things a little bit. Okay. And then you have cryoprecipitate, which replaces fibrinogen and other clotting factors. This is not something that you're going to be commonly giving. It's very patient specific, and it's for hemophilia or other inherited bleeding disorders. So if you do not have a bleeding disorder, then you're not going to get this. The only person that's going to get this that like doesn't fall into this category is a patient that's gone into DIC or what's the other one? HELP syndrome, the heparin induced. Platelets or something. I don't remember. Okay, so those are your different types of blood products. So blood transfusions. Majority of transfusion reactions other than those due to procedural error are due to the presence of donor leukocytes within the blood component. I just told you, I don't want whole blood. I don't want other people's white blood cells. That's not good for me. Okay? So, when I'm giving blood, pre-procedure, you want to look at your patient's comorbidities. Okay? Does your patient have a significant history of CHF with significant peripheral edema? They're anemic. They need blood. Do I want to probably be careful and make sure that I'm monitoring my patient for fluid overload during my blood transfusion? Yes. Yes, I do. A history of a blood transfusion reaction. Super important. A baseline assessment. This includes all of your vital signs. You have to get vital signs right before the initiation of a blood product. Patient education. What to expect. Let me know if you feel weird, if you feel short of breath, if you feel your heart racing. Okay? You must ensure that the patient has had a type-in screen within the last 72 hours. And you must ensure they have what size IV? At least a 20 gauge. Yes. Preferably if you can get an 18, which is not common, a 20 gauge is fine. Can you go smaller? No.
That's for
No.
kids.
You cannot go smaller than a 20 gauge IV for blood transfusions. Okay? For the procedure, you must have a dual sign off. So that is 2 licensed, keyword, people that are signing off on your blood. Okay? Oh, I'm sorry, I forgot IV. Obviously make sure. Oh, no, I didn't. But again, also with the IV, make sure your IV is patent and working. That's what I was thinking about. So when you are giving blood, you have to get another licensed provider, and you have to look at the blood product, the order sheet for that patient, and you have to cross-examine and make sure everything matches. The patient name, birth date, medical record number, the unit number of the blood type, the expiration date. These are all extremely important and mandated throughout the country. Every facility, every time. We do not take shortcuts on blood products. You know, there's some times where it's like, oh, real world versus NCLEX. There is no real world versus NCLEX when it comes to blood transfusions. It is always one way, and that is the only way. Okay? During the procedure, the RN that initiates the blood transfusion must stay with the patient for the first 15 minutes. No ifs, ands, or buts about it. They must stay with the patient for the first 15 minutes. This cannot be delegated because the majority of transfusion reactions occur within the first 15 minutes. At the end of those 15 minutes, you must take a second set of vitals. Okay? After the fact, after that first initial 15 minutes, you can then delegate the next set of vital signs to an unlicensed personnel. So your tech on the floor. Hey, my patient's getting blood. They need vitals in an hour. Can you grab them? Yes. Okay. Post-procedure, as soon as the blood ends, you should get vital signs. Document that you have given the amount of blood that was given. Dispose of the blood bag and tubing properly. It comes with a hazard blood or a hazard bag, biohazard bag. Thank you, biohazard bag, and monitor the patient for a patient response. Because, like I said, most commonly, the reaction is going to happen within that first 15 minutes. But there are specific reactions that can happen hours to days later. Okay? Blood transfusion reactions. You have febrile non-hemolytic reaction. Hemolytic, what does that mean?
Destroying the blood cell.
Destroying the blood cell. Lysis. Lysis means destruction. Lytic, destruction. So, non-hemolytic. There is no destruction. There's a fever, no destruction. The second one, acute hemolytic reaction. Destruction. Bad. Bad, bad, bad. Allergic. Your body attacking the blood? Yes. Or vice versa? Yes. Allergic hemolytic reaction. Literally allergy, histamine response, anaphylaxis. And we're going to talk about trolley and taco. I would implore you to know the difference between trolley and taco. Does it go over it? Ah, shoot. Okay. Trolley is transfusion related acute lung history or injury. Jesus. So this is a rare life-threatening transfusion complication that causes severe, write this down, trolley is a rare life-threatening transfusion complication that causes severe non-cardiogenic pulmonary edema. That means it's not caused by the heart failing. It is not caused by the heart failing. It's non-cardiogenic. It has nothing to do with the heart. So it has
non-cardiogenic pulmonary what?
non-cardiogenic edema and hypoxia. This usually happens within 6 hours of the transfusion. It is the leading cause of transfusion-related death. So this, it says the cause is primarily linked to antibodies in the donor plasma. And it causes the vessels in the lungs to leak fluid into the lungs. That's where the pulmonary edema comes from. Because normally when you see pulmonary edema, it's coming from heart failure, right? But I'm telling you, it's non-cardiogenic, has nothing to do with the heart failing. Okay? So the process of trolley occurs because fluid is leaking from the capillaries that are inside the lungs, filling them with fluid. It is an it's basically an not an allergy, it's an immune response because it reacts to the antibodies. So this is an immune
So have
system
you seen
response.
this, Mrs. Simmons?
I have seen taco. I have not seen trolley with my own eyeballs. Thankfully.
So that would be like essentially drowning.
Essentially drowning, yes. 100% yes. Okay.
I have a question.
So, go ahead.
So that can happen like even if the person like they got the right blood, everything's compatible, that can still happen?
Yes, ma'am. Yeah. It's because we do we look for so many antibodies. They try so significantly to match, to cross match everything. But unfortunately, things still slip through the cracks, which sucks and is scary. But die from blood loss or maybe die from trolley. I guess if I have to choose one, I'm probably going to choose the one that's less death even though they're both death, both not a great situation.
Are there
Okay.
interventions for that if that happens?
Yes. So treatment is unfortunately only supportive treatment, which include oxygen and mechanical ventilation. Which is why the mortality is approximately 10 to 15%, according to Google. Dr. Google. Okay, so Taco is transfusion-associated circulatory overload. This is caused by fluid volume overload and is caused by truly the backup of fluid into the lungs. So one trolley is caused by the immune system and an antibody reaction. Taco is caused by fluid overload, hypervolemia.
That happens to dialysis patients when they get blood transfusions and do not get dialysis right away.
That's why a lot of, especially in acute care, a lot of people that need dialysis will get the blood transfusion during dialysis. So they can control the fluid volume. So, if
Is
your
that what
patient,
CRRT is? I'm sorry.
no, CRRT is continuous renal replacement therapy. That is continuous dialysis. That is a completely different thing. So blood transfusion reaction treatment. Number one, you stop the transfusion. That is always going to be the answer. Never assume transfusion was stopped unless it says it in the question. Never assume. Number two, assess the patient. Do you leave your patient? Never, never leave your patient. You say, hey, I need help in here. And the people come. Number three, you notify the provider. Number four, you notify the blood bank. The blood bank is going to want the bag. They want the bag, they want the tubing, they want everything. Because they have to figure out what happened. If hemolytic or bacterial reaction is suspected, you want to get samples of blood, urine, and cultures. And then, of course, once everything is said and done, your patient is safe, stable, hopefully not dead. You document the reaction. See why there's no difference between real world and NCLEX? Because people die if you take shortcuts. Blood transfusion complications, these don't really happen anymore. Truly, because of how far we've come with technology, they don't happen a lot, but it can still happen, I guess. Which I think this is why I'm not allowed to give blood within a certain time frame after a tattoo, because getting a tattoo puts you at a higher risk of contracting a bloodborne pathogen, like hepatitis B, C, HIV. Okay, so complications include hepatitis B or C, HIV, cytomegalovirus, graft versus host disease, and Creutzfeldt-Jakob disease, which I believe is mad cow disease. I'm pretty sure.
I think it is.
Oh, maybe not. CJD, yeah. There's two things that cause it. One called BSE and the other one is CJD. Oh, CJD is the human variant. BSE is the animal variant. Questions about blood? Questions about anything?
So basically, this whole slide is going to be test 1. Not this whole slide,
Yes.
but this whole PowerPoint.
Yes.
Okay.
Plus maybe a teeny tiny bit of nutrition. Not a lot of nutrition, that's for sure. Because I told you I'm not testing you heavily on nutrition when you're already being tested on it.
Next week is only one point.
Next week is all neuro, traumatic brain injury, spinal cord injury.
So it's just that one big PowerPoint.
Mm-hmm. Yeah, it's just the one.
And you said there will be a PowerPoint till week 3.
Yeah, I just gotta get it on there.
I just like that.
I'll work on it. All right.
For the
Any
ATI
questions?
video, unrelated, but for the ATI video case studies, it says on Brightspace, but I just want to verify we don't have to upload anything from those.
Yes, you do. Listen,
Okay.
I don't know why it says that anything transfers to Brightspace. It's a lie.
I was
It's a big
thoroughly
fat
confused
lie.
by that too.
When you
Okay.
finish the case study, when you submit your first question, like your answer, and then you watch this for video and submit your reflection, it says it sends it to our instructor.
Never seen one in my life. Never seen it in my life. Not
Yeah, it
one
says it
time have
sends
I
you
ever
our, like,
gotten a notification that says, Jessica Simmons, you have 42 ATI case studies to review. Never in my life. Never seen them, not one time.
So that's so weird because we have to like go through and we have to do like respond to the video and like what
I
would
know.
we do or what would whatever. And then it says it sends to the instructor and then we have to do the quiz. So you want us to upload the report from the quiz that we do then basically? Okay.
Yes, ma'am.
But on my report, it doesn't tell
So
you
how
my
will you get the
reflection.
results?
Just so there's no way to
Well,
get
we
those
can't send
reflections
anything
back.
from like our video response. It'll just be the report from the test.
I want the quiz.
Okay.
So you don't care about the question, the video thing. You just want the quiz after because
Now. You have
I
do the
to do it. Right, but how will you like? How are we going to upload that?
Like tell you what is going like the answers to the
You
quiz.
just so you guys after you do it, it tells you like there's like the results next to it because it'll say like access the case, retake the test or results. So you would just do the results and download that report and that's what she wants.
Correct.
And it tells you how much time we spent on the case study on that and then the test.
Yeah. Let me see. Student roster. Oops. Let's see. Jane is the first person I see on this list. Let's see. Studies. Oh, I haven't seen anything there. Yes. I'm so excited for my antibiotics to work. Yeah, it's been 15 minutes. Like that's what I do. Hold on.
Are we required to get 100% on the quiz for you, or is there a minimum grade you want for that?
I don't know. Does it have that on the,
It says first attempt.
it just says first
I
attempt?
looked and I don't think it said anything.
It does. It has like the points you get by whatever you get on the test. They're only like 5
Oh, yeah.
questions.
Yeah, like half of the points is for doing the video study, and then the other half of the points is what you get on the,
So if you get a
quiz.
90 to 100, it's 50. If you get
Yeah.
80 to 89, it's
yeah, it's on the syllabus. Hold on, I'm trying to find these case studies and see if I can see your answers.
There's even a space for our instructor to write a response to us.
It's so funny.
But we had to do them in med-surg, and I'm pretty sure Tammy couldn't get them either.
I can almost guarantee.
'Cause, like, you watch the video, you answer the question, hit submit, it says it's sent, you do that.
So I can go to analytics. I can see the time spent. Girlfriend only spent 5 minutes and 34 seconds on hers.
What? Oh,
Mm-hmm.
oh, baby, look at all these notes I wrote for you.
Miss Sandra Campbell spent 1 hour, 3 minutes and 10 seconds though. Wait, hold on, let me see. I want to see if it gives me the response.
Right here, person, seven, so you would upload that.
No, I don't want that. Come on, load.
Yeah, it says instructor feedback, review your score and feedback. Once your instructor reviews your submission, your score and any feedback will appear here. It says it's not graded.
Let me see. Individual. Okay, so no, even when I download the module report, I see that you got 100%. And it literally does not. It's a scam.
So basically.
Module summary? Let me see, hold on.
Basically.
I mean,
Yeah.
yeah, it gives you some type of AI feedback. That's not from me.
Well, the blood administration one's literally, the first video is like 52 seconds and the second video is like 30 seconds.
Nada. Educating resources. Yeah, I don't know. I don't know what to tell you. I don't know what to say about that. All I know is I can't see the responses. That's all I know.
Miss Simmons,
Yeah.
do you know if we bring in like a Texas Instrument calculator at our when we go take this test, will they let us use it?
I don't know. Yeah, it's I think that's against like school policy.
Basic desktop. Little bigger.
Yeah, I've asked for Brights to like incorporate a math test or a calculator into Brightspace, and apparently they can't do it.
Can we bring up the calculator on the computer?
No, that's cheating. Listen, I don't make the rules. I don't make the rules. All right. It's 1:46. We have to take our math test at 2:30. Is there anyone? I'm gonna go into Brightspace and I have to double check that everybody did their module. Did you upload your report for your math module? Because if not, you will not be allowed to take the math test. I'm gonna go look right now.
I only uploaded the report from the test, like the math test. Was I supposed to upload 2 things?
No, that's fine.
Okay, thank you.
I don't see any. Oh, here, math. I have 39 submissions. I'm missing 1. I am missing 1 person. And I do not want to call you out in front of all of these people. Where are you? Are you in here? Yes, you are. I'm going to send you a private message.
Then I spent 26 minutes thinking.
I sent you a private message. Please respond to me. I know you're in here. Because I can see your name.
Are we okay to go and head to campus?
Yes.
Thank you.
You're welcome. Good luck.
Thank you.
I'm gonna have this video uploaded hopefully by tomorrow morning. And I'll probably send key points by Friday night.
That's the bond. Is it on Mondays or Wednesdays? I think it's Monday. I thought math was wrong.
Let me make sure.
I think it's vice versa.
Let me make sure.
Test is at 8 a.m. Monday morning.
8 a.m. Oh my God, thank God you said something. I would have been late.
And then lecture is 9:30.
Did everybody see that our exam?
So then math is
Their math module is in there. Left.